Okay, we'll start from yes, May recalls. And as I promise, I will do this is May exam week day one records because everyone know like I'm doing my record classes like part wise because the thing is I really want to explain very deeply each topic, so that's what. So this is still day one recalls the part two because I got this one. Like we can cover a lot topic from here. And one more thing, the doctors are asking about the AMC crack plan and everything. So I'm thinking of doing it in this week. So yeah, I will explain everything like the guidelines and all the like guidance you need, the time and preparation and everything. So don't worry. I remember you don't have to ask every day. Okay. Yeah. So I'll do it somehow. Okay. So don't worry about it. This week, I promise. Okay, this first question in this file. All age smoker, painless hematuria, what to do next? CT abdominal, urodynamic study, ultrasound. You know, this question came on June as well. So, not the exact question, but in May, if you are done very deeply this question with the proper theory, you can, even though you have done the exam in June day one, you can still answer this one. Okay, before that, we'll do this question. Then we'll come back to our question. Okay, 65-year-old man presented to the GP clinic with 3-week history of intermittent passage of blood in his urine. The blood is mixed with the urine and not associated with any pain. He has no significant medical history and does not take any regular medications. On examination, she appears well, vital signs within normal limit. Digital rectal examination revealed moderate smooth enlargement of both lobes of the prostate. Urine analysis and urine culture are arranged and a urinary tract infection ruled out. Reason? Serum biochemistry and electrolyte are within normal ranges. Which one of the following most appropriate next step in management? Now type your answers in the chat. Then I will explain from this question. What do you think, doctors? Type your answers. Starting with a better question. That is good. Okay, what about other doctors? Please quickly answer. Yes. Okay, here. You're correct. The answer is CT urogram with IV contrast. Very important, okay? This patient has 3-week history of frank hematuria. In all cases, macroscopic hematuria, benign cause must be assessed with a preliminary investigation such as urine analysis and urine dipstick performed as in the stem. Following a negative urine culture, malignancy must be considered and excluded. This patient will need pelvic and abdominal imaging as well as cystoscopy. In practice, as this patient has presented to his GP, it will easier to get some image performed before the patient see a urologist. A CT urogram with the intravenous contrast is required for patient with gross hematuria as the IV contrast line the collecting system manipulator which will identify any filling defect such as urothelial carcinoma as well as solid renal tumor and urinary tract calculi, while cystoscopy and other invasive investigation are the more sensitive for detecting malignancy. It is more feasible for GP to arrange for image while the former being organized. Therefore, the making CT urogram with IV contrast most appropriate. Can you understand? If you are suspecting a urothelial cancer, the best thing you need to do is what? You need to do the cystoscopy. But to do the cystoscopy, you have to first refer for the urologist. Then under urologist, you can do this cystoscopy. under his guidance. But before that, if you are in a GP setting, anyway, like initial thing is GP setting, in a hospital setting, what you need to do, you in that case, like a patient is delaying for the cystoscopy. Because of that, the next best step is doing a CT urogram with intravenous contrast. This imaging can give a prior idea before the cystoscopy. Very important, okay? And here, the cystoscopy will be needed to investigation the lower urinary tract. However, first of all, it must be determined whether there is any upper tract pathology such as suspicious of urothelial carcinoma. If a upper tract issue is identified, then uteroscopy can be performed at the same time as cystoscopy. Renal carcinoma should be considered and exclude all patients with persistent frank hematuria. Very important. Now I will explain the theory part clearly, okay? Here. So first of all, what is hematuria? Hematuria, what is it? Presence of red blood cells in urine, right? Red blood cells in urine. So you have two types, macroscopic and microscopic. So macroscopic means the visible hematuria, right? Visible in blood, right? Visible blood in urine. Doctors, can you mute your mic? Which mic is on? Dr. PB, can you mute? Okay, thank you. Otherwise, my consistency is breaking, right? Yeah. Okay, so we were discussing about the types microscopic. That means we can't detect on our eye, visible eye, but you can detect in urine microscopy. Very important. And here, always remember the painless macroscopic hematuria in adults, especially in older people, malignancy until proven otherwise. You have to exclude malignancy, very important. We are painless macroscopic hematuria, very important. Okay. Okay, what is happening? Sorry for that. Yeah, here. So causes for the hematuria. You have transient cause, exercise induced, trauma induced, sexual intercourse, pelvic organ prolapse, vaginal atrophy. These also can be a cause for the transient hematuria. There can be malignant, as we discussed, urothelial cancer, prostate cancer, renal cell carcinoma. All can make this malignant. All can make this hematuria. Infectious inflammatory pyelonephritis also can be one cause, and lower urinary tract infection, radiation cystitis, and foreign body or urethral caruncle. The renal medical diseases like immunoglobulin A, nephropathy, thin basement membrane disease, hereditary nephritis, those things also can be a cause, right? Because we all know nephritis can present with the coke color hematuria, right? Very visible hematuria. I hope you have went through the June record class that I have uploaded in YouTube. I have explained very clearly nephritic and nephrotic syndrome. Please watch those things, doctors. I don't know. I'm like taking so much time to upload, and like it also hard work. Okay, and I have to cut down and edit the videos. It will a huge effort from my side. So because of that, please cover those things, because it's like you can cover more than you can cover like once a syllabus from my YouTube channel. Okay, so watch those things. Okay, yes. Okay, then other things are obstructive causes like urolithiasis, stones, and BPH, benign prostatic hyperplasia, hyperplasia, prostatic regrowth. Okay, so these are the causes that can be associated with hematuria. So the clues, very important clues. These are the key things that you need to understand. If it is a painful hematuria, painful causes, you can think about stones or infections, right? If it is a painless hematuria, you can think about malignancy. Anyway, you know, painless hematuria, visible hematuria, until proven otherwise, you have to think it as a malignancy, right? With proteinuria and hypertension, you can think about glomerular disease, right? The proteinuria associated with nephrotic syndrome, hypertension, and what else? This hematuria can be associated with nephritis, right? Okay. Okay. So the investigation approach. So we have two guidelines. Okay, we have RSCGP two guidelines. So I have attached two of this, but my preference is this one. This is the better one. You can find in Google hematuria RSCGP guideline. I prefer this one because this can cover a lot for AMC. Let's start the investigation. Primary care presentation with hematuria. So history and examination. So UTI or transient, benign cause suspected, you have to exclude them, right? You can do the urine analysis, right? Repeat microscopy within 6 weeks. If it is infection present, you have to treat accordingly. Okay, here. The microscopic hematuria and macroscopic. Microscopic hematuria, 3 RBC. Okay, macroscopic mean the visible hematuria, macroscopy, visible. So here, if it is a microscopic hematuria, risk stratification you need. So what is risk stratification? Because this part is very important. They are asking question from this specific part. So you should know what are the risk factors here, because according to these risk factors, you have decided the investigation. Here is factors. Age more than 50. This is for microscopic, okay? Microscopic. Age more than 50 years. Smoking history, occupational exposure, irritative low urinary tract symptoms, history of gross hematuria, prior pelvic radiotherapy, or recurrent urinary tract infection. If these risk factors present, you have to follow this path. I'll explain. If it is not present, like a low risk, consider repeat microscopy within 6 months, right? So that is enough. Enough for that. This is for microscopic hematuria. So if it is macroscopic hematuria, you need visible bleeding, right? You need to do the imaging or adjunct. CT, IVP or renal tract ultrasonography, consider urinary cytology. So here also, if it is, even though if it is microscopy, presenting with these risk factors, you need to go with these imagings, right? So CT, IVP, very important. I will explain. So after that, urological referral, because this is the first step, then after urological referral for the cystoscopy. That is cystoscopy also must if you are suspecting like malignancy. Okay, so CT IVP. Again, they have mentioned if microscopic hematuria with red flag presence, CT IVP is a gold standard for assessment of urinary tract malignancy. Very important. Here, these tiny points they are clearly mentioning, right? Okay. Okay, doctors, that is the important thing. And here, these features, very important. Risk factors for urinary tract malignancies. Increase in of age, especially more than 40. Here, these are the another risk factors. History of smoking, both current and past. Occupational exposure to dyes in the prints and clothing industries, benzenes, exposure to medications such as cyclophosphamide or phenacetin, previous pelvic radiation, history of macroscopic or visible hematuria, significant bladder symptoms in the absence of urinary infections like urgencies, frequencies. Like if these features also given associated with these cases, you can think about urinary tract cancer. Okay, very important. Very important. I hope everything is clear. And I have attached another question. 66-year-old man to the GP clinic with 2 week history of intermittent painless hematuria. He has no other urinary symptoms. He has significant medical history and take no regular medications to a 45 pack year smoking history. Currently smokes 10 cigarettes a day. He drinks about 2 glasses of wine most day. On examination appears well with vital signs within normal limit. Abdominal examination reveal no abnormalities. Microscopic examination of urine confirmed presence of red blood. Okay, microscopic examination. So now tell me, here is a painless hematuria. Now tell me which one of the following most appropriate next step in management. What do you think? Tell me, doctors. Mm-hmm. Okay, okay, interesting. Good. Patient presenting with painless hematuria which require thorough investigation due to the high risk underlying neurological malignancy, particularly given his significant smoking history. The approach to investigation hematuria involving imaging of the upper urinary tract and direct visualization of the lower urinary tract. The practicalities of this process will be a general practitioner to arrange image studies and make the appointment to the patient to see a urologist. The reality will be that image studies can done almost immediately with specialist appointment may take several weeks. So CT urogram, the same thing, CT urogram, CT IVP. Remember, either look for CT urogram or CT IVP. Initial investigation in this case provide the comprehensive imaging of the entire urinary tract with high sensitivity for the detecting renal masses, urolithial tumors, urolithiasis, or other potential cause of hematuria. 66-year-old man with significant smoking history, risk of urological malignancy. Subsequent making CT urogram is preferred imaging modalities due to the superior sensitivity compared with ultrasound, right? Okay. I'll show the cystoscopy part as well. Essential component of the evaluation of hematuria would likely to be performed after initial imaging, right? It allows direct visualization of the bladder and urethra and sorry and particularly important for detecting bladder tumors. However, it does not evaluate the upper urinary tract, so it would typically follow a complement imaging rather than replace it as the first investigation. Have you understand? Have you understand, doctors? Right here with the risk factors, microscopic examination, even though smoking history and age more than 50 is a very risk for the cancer, right? So because of that, you need to, can you see, is recalls harder if you get this much recall, that the tiny version is also enough in exam week also. This is the way you need to do, like not this very slowly, because you are always oriented. Just if you see a question, you need to know what is hematuria, two types, what is the investigation algorithm, what is the definitive investigation, and like initially what you can do, why you are doing imaging prior to the cystoscopy, the thing is it can be delayed. Because of that, better to do a initial imaging like that. Okay, so you need to think this as like a story, right? Like a storytelling in your mind, everything should be there. Then after that you can answer any question from hematuria, right? Any question like related to these the urothelial masses or cancer related to question, right? So here CT abdomen aerodynamic study ultrasound, actually CT abdomen, like go with check for the CT urogram, right? Urogram or CT IVP, because you have seen they can give like this CT urogram with IV contrast or CT IVP or CT urogram. Okay, like that. I hope this topic is very clear for you. Okay. Uh, okay. 80-year-old lady developed severe back pain after bending. Past history of colon cancer diagnosis. Metastasis, compression fracture, osteoporosis, sudden vertebral pain after minimal trauma in elderly woman, osteoporotic compression fracture. This is the to recall we got. Okay. So we'll discuss about this back pain. So what do you know about back pain? Okay, I'm going to ask a question about the back pain. So, when do we need imaging or some kind of investigation for the back pain? When we are going with back pain imaging? When? Okay, I already explained this part in some kind of class. I can't remember. Yes. So I told you to remember those red flag as what? Those red flags as the tuna fish. Can't you remember the tuna fish? Tuna fish? Very easy. Remember these red flags for back pain as a tuna fish. Tuna fish. Okay, how? So T mean the trauma. If a trauma present, you need to think about what you need to think about some kind of imaging, because all the back pain, for all the back pain, we are not doing imaging. We are not doing imaging. Okay, very important. Keep these points in your mind. But if it is a red flag, you need to find out what is ongoing, right? So you mean unexplained weight loss. Okay, so, N mean neurological symptoms. I will explain. Okay, don't worry. Neurological symptoms present. Then A mean age less than 20 or more than 50 to 55. Okay, because I have given these 50 and 55 because e-medicine they have mentioned 55, and the Australian guideline they have mentioned 50. So that's what, take it as 50 to 55, more than 50 to 55. So if mean fever or signs of infection, I mean intravenous drug user, intravenous drug abuser or immunosuppressed. Okay. S mean steroid use, H mean history of cancer or HIV or TB. Right? So tuna fish, easy. Here again the red flags, because these are the red flags. Like from here you can easily remember. Age less than 20 or 55. This is from me medicine. History of cancer, unexplained weight loss, fever or signs of systemic illness, immunosuppression, including HIV or use of immunosuppressive medications, intravenous drug use, recent significant trauma, minor trauma in old age, prolonged use of corticosteroid, severe unremitting night pain, especially if not related by rest, a structural deformity of the spine, significant neurological deficit including progressive motor weakness, subtle anesthesia, new onset bladder or bowel dysfunction. Right? This are associated with the neurological signs associated with most of the time cord compression. Okay, something that can compress this spinal cord, right? So because of that is a red flag. Okay. Okay, before that, we'll do some questions. Then we'll come back to theory part. 92-year-old man present to the uh, ED with 1 week history of new onset mild back pain and weakness in his leg, which is reducing his mobility and function. He has a history of metastatic prostate cancer and currently receiving palliative care at home with no active as a treatment. He has no significant medical history and take no regular medication other than as needed analgesic. On examination, he appears frail to vital signs within normal limit. Neurological examination reveal weakness in bilateral lower limb with reduced sensation below T10 nerve root, including reduced perianal tone. An urgent CT scan in his thoracic spine shows the new metastatic disease at T10 causing spinal cord compression. Which one of the following is appropriate next step in management? Okay, so I'm going to read the options. Read the options. Listen carefully because I want answers from you. The options are hospice admission, palliative chemotherapy, urgent neurosurgical decompression, initial steroid, urgent radiotherapy. What do you think? What do you think, doctors? Okay, I'll show the question again. Okay, I'll show the question. Okay, so answers are hospice admission, palliative chemotherapy, urgent neurosurgical decompression, initiate corticosteroid, urgent radiotherapy. What do you think? Okay. Okay, tell me what is the problem in here? What is the problem in here? At the moment, what is the problem? What is the most concerning problem in here? Tell me that, then you will understand what is happening at the moment. Here, 1 week history of new onset mild back pain, weakness in his leg, reducing his mobility and renal and function. History of metastatic prostate cancer. Okay, history of cancer. And CT find out thoracic spine shows the metastatic disease at T10, causing spinal cord compression. At the moment, appears frail with vital signs within normal limit. Neurological examination revealed weakness in bilateral lower limb. At the moment, cord is compressing, right? Cord is compressing. So at the moment, what you need to do? You need to give steroids. Can you see? You need to give steroids. Why? Patient present with clinical and radiological evidence of malignant spinal cord compression. It's an oncological emergency. At the moment, it is compressing it, right? You need to treat it immediately. The most appropriate next step is initiate steroid. High dose dexamethasone should be sorry for that. Sorry. Dexamethasone should be started immediately to reduce spinal cord edema, potentially improving neurological function and providing pain relief. At the moment, thank you, doctor. At the moment, the problem is cord compression. Why? Because of this malignant cord compression, right? Because there's a cancer in thoracic T10, right here. They have confirmed, and they at the moment patient is presenting with this weakness, bilateral lower limb, reduced sensation, right? At the moment it's compressing. You need to do something. It's an emergency, right? So identify the problem. They will give like the very like a long way description. They really want you to distract. So keep in mind, if you see these things, go with this. Like the concept should be more clearer, right? More clearer with this kind of question. Okay, here. Then high dose of dexamethasone should be started immediately to reduce spinal cord edema, potentially improve neurological function and providing pain relief. No, it doesn't matter, doctor, elderly or anything. Just initially steroid because compression present, right? Edema present. You need to reduce it the urgently, right? In that case, you can give corticosteroid, right? Because this is what malignant spinal cord compression. So, urgent radiotherapy is typically the definitive treatment. The definitive treatment, urgent, sorry, definitive treatment is urgent radiotherapy and should be arranged to follow corticosteroid initiation as soon as possible because the problem is a compression. The definitive treatment is radiotherapy, but you need to do the decompression, right? By giving this steroid, right? Steroid is a miraculous drug in this kind of situation, right? So idea here, initiate as soon as possible, ideally within 24 hours. While this option is not incorrect, initiating corticosteroid is the more immediate step and can be done while arranging radiotherapy, right? So, urgent neurosurgical decompression might be considered in some cases, particularly in patients with good performance status, limited comorbidities, and life expectancy of more than 3 to 6 months. However, given in this patient advanced age, frailty, and palliative state, the risk of surgery like outweigh the potential benefits. We can do, but most appropriate, like in younger patient, can go with urgent decompression, neurosurgical decompression, but like if it is be delayed or like better option because it can act like very quickly, right? If you give the steroid, that it can act very quickly and give this relief, right? And they are giving it can consider in some cases like, yeah, consider. But here's the most initial thing. Better start with this steroid, right? But keep this point as also in mind. Here they have mentioned good performance status, limited comorbidities, life expectancy more than 3 to 6 months. Yeah, can it be? Okay, so palliative chemotherapy, not typically used as a urgent treatment for this malignant compression, right? Okay. Other than it is important to note that while initiating corticosteroid is the most appropriate immediate step, the decision is to pursue the further treatment such as radiotherapy should be made in context of the patient's overall goal of care, considering his age, cancer type, and current palliative status. A discussion with the patient and his family and the potential benefit and risk of treatment as well as their preference should guide final management decision. Urgent corticosteroid and radiotherapy are the first line treatment for malignant spinal cord compression with patient with metastasis cancer. Malignant cord compression in oncological emergencies require prompt diagnosis and treatment to prevent irreversible neurological deficit. The goal of care in advanced cancer patients should be considered when deciding the aggressive treatment. I have attached this question for your extra knowledge. Okay, extra knowledge to get an idea. Let's go back to this one. The clinical assessment. Okay, the focus history. Okay, about the back pain. The focus is to take in pain profile, functional limitation, and stratifying the patient into the aforementioned mentioned categories. It is recommended an examination includes a range of movement, sagittal and coronal alignment, nerve root tension sign, abdominal palpation like neurological examination. Everything should be done initially. Indication for imaging include patient with red flag, abnormal neurology or pain lasting more than 4 weeks. Very important. Very important, doctors. Okay. Erect plane radiograph can be used to define a spondylosis, spondylolithiasis, or scoliosis. Importantly, sclerosis, osteophyte formation, and loss of disc height indicate a degenerative process. If there is an ongoing pain or concern, advanced three-dimensional imaging with the CT and or MRI is appropriate. CT is often the imaging modality of the choice when access to MRI is limited. The authors suggest the early imaging with MRI under the guidance of an orthopedic spinal surgeon. If the patient is severe unremitting radicular pain, abnormal neurology, red flags, or failed or non-operative treatment, the correlation between MRI and this disease and LBP is low and therefore warrant caution interpretation. Nuclear imaging those things. But okay, here, if it is a mechanical pain present, you don't need to go with any imaging, right? No imaging. If without red flag but suspected fracture is, you have to go with the X-ray first. If it is neurological deficit or malignancy suspicious, you need to go with MRI. Okay, I have here attached a few guidelines because we have discussed this question earlier. This is the repeated part. I will show in e-medicine. There are good questions for back pain because you need to understand. You need to understand all the 1 minute. You need to understand all the scenario because that is very important. Okay. Oh my God, back pain can't do 77. Let's see. Some questions I remember. Okay, we'll do this one. 61-year-old man present to the GP clinic with 2 week history of lower back pain. He first recognized pain while he was carrying 7-year-old grandson. The pain is consistent during the day and is worse upon movement. He has difficulty in sleeping due to the pain, which he rates 6 out of 10. He denies having any morning stiffness, radiation, pain, or limb weakness. Bowel and urinary changes, nothing present. Its history includes the polymyalgia rheumatica, diagnosed 2 years ago, which is treated with the long-term oral corticosteroid. On examination, blood pressure 125 by 85, respiratory rate 16, temperature 37. There are no obvious musculoskeletal deformities and no bruising. There's a focal tenderness on the lumbar spine, lateral flexion, and the lumbar spine limited due to the pain. Lower limb examination and digital rectal examination are unremarkable. Now tell me which one of the following most appropriate initial investigation. This is a very good question. This is a very good question. If you want, I can share the link after the session, the question link. Tell me, doctors, what is the answer for this question? Okay, you are going with the spinal X-ray. Let's check. Yes, correct. Why? Here, back pain is very common presentation in primary care setting. Most patients with back pain will do not require additional investigation. However, further investigation is recommended in this case due to its current corticosteroid treatment. Right? The most appropriate investigation in this case is spinal X-ray. Imaging is indicated as oral corticosteroid increase the likelihood of fracture and infection. Its acute presentation and night pain are also concerning features, making spinal imaging more appropriate. Other red flags which indicate need for further investigation, including history of trauma, limb weakness, history of intravenous drug use that we discuss as tuna fish, right? A long-term corticosteroid use is increased risk of fracture and infection because here we are suspecting fracture, so you need to do the spinal X-ray, right? It's a good one. Let's do few more questions. Then you will some questions I remember when I see. So easy question. That's fine. We'll cover the this my case on. mm, Sorry, just mute. Why I can't mute some doctors? Okay, Dr. Kevin, can you mute? A 68-year-old man presented to the emergency department with sudden onset lower back pain after lifting a heavy box of books. He reported background of early morning stiffness and back pain that improved with the movement over the past year. He has been experiencing increasing fatigue over the several months. This is not related. Month struggling to complete daily activities. Early morning stiffness present. It's okay. We'll do this one as well. He has lost 5 kilogram in weight. Has no significant medical history and take no regular medications. On examination, he appears tired but well. Pulse rate is 82, BP 135 by 85, respiratory rate 16, SpO2 98, temperature 36.8. There's a tenderness over the lumbar spine, but normal range of movement. Physical examination otherwise unremarkable. Hemoglobin 82, WBC 4.2. Serum calcium 2.59, serum sodium 128, erythrocyte sedimentation rate 85. Which one of the following is most likely to diagnosis? It's okay. It's also some kind of back pain. What do you think? Mm, yes, because I was telling not related because in our file I have this. We have this question as one of next question. That's what. I will explain once we are doing it. Okay, so don't think about that question. Okay, this we'll do this question answer. 42-year-old woman presented to the GP clinic with a 3-day history of lower back pain after gardening over the weekend. The pain is localized to her lower back without radiating to her leg. She reported difficulty getting out of the bed and getting dressed due to the pain. She has no significant medical history and does not take regular medication. She works as an office administrator and has taken 2 days off work due to pain. She's concerned that movement will worsen her condition and been resting in bed since pain started. On examination, she appears well. Vital signs within normal limit. Has tenderness over the lumbar paraspinal muscle bilaterally without midline tenderness. The straight leg raise is negative bilaterally. She has normal power, sensation, and reflexes in both limbs. Which one of the most appropriate management advice? Now tell me the answer. Because this question, the exact question they have asked during past months. Okay, you all going with A. Let's see. Yes. Here, this patient present with non-specific lower back pain. The one that you don't need any investigation. This is a very important. This exact question, doctor, they have given. Okay, this question they have given. So very careful. Patient present with acute non-specific lower back pain without any red flag suggesting serious pathology. Absence of neurological symptoms, normal neurological examination, mechanism of injury consistent with musculoskeletal caused pain. So remain active with modified activities as tolerated is the most appropriate management advice based on high quality evidence. So research consistently shows that staying active improve the pain relief, functional outcome, reduce sick leave, and enable. The basic thing is patient should be remain active without inactivity. Okay, remain active. Okay, that is good thing. This question, please, if you are not done, haven't done this question, like screenshot and do it. Okay, very important. I'll share these links, then you can get an idea. Because this file I don't, I think the previous file I have attached it. There was another one question. I was, it's fine. Like we don't have examination for months mid back pain. Okay, this is a good one. Another. This is the last one for this back pain. Okay, 72-year-old woman present to the GP clinic with 4 months history of persistent mid back pain. The pain began after she bent forward to lift a light shopping bag and has gradually improved but not resolved. She has noticed her clothes fit differently and that is she now approximately 4 centimeters shorter than her previous documented height. She underwent menopause at 50 and never used hormonal replacement therapy. Mother sustained hip fracture. In her 70s, she has no history of malignancy, weight loss, or fever or neurological symptoms. On examination, she appears well. There's a focal tenderness over thoracolumbar junction and mid-thoracic kyphosis. Neurological examination normal. Which one of the following most appropriate management? Okay, we got. What about other doctors? Mm, okay, we got B, D. Most doctors are going with D, right? Okay, let's check D. No, your answer, okay, not my answer. Okay, here, what is happening? The patient has several features suggesting of osteoporotic vertebral compression fracture. This is a good question for uh, our recall, right? Including persistent back pain following a minimal trauma. So, documented height loss, thoracolumbar tenderness, postmenopausal status, and family history of fragility fracture. The most appropriate initial investigation is thoracolumbar spine radiography, which can identify vertebral height loss, wedge deformity, end plate collapse, and other features of vertebral compression fracture. right? The plain thoracolumbar radiography are the initial imaging modality of choice for suspected vertebral compression fracture. The typical radiographic finding including anterior wedge deformity, loss of vertebral height, biconcave deformity, and endoplate collapse. So, vertebral fracture are commonly defined as a radiographically by reduction of vertebral height at least 20% or compared with the expected vertebral body height. If a low trauma vertebral compression fracture identify a clinical diagnosis of osteoporosis can generally made by regardless of the bone mineral density, right? So I will share all of these questions, then you can get an idea, right? I hope this is the best question, right? If you're suspecting any fracture, even though it's a compression fracture, do a imaging. If you're suspecting any fracture in your spine, do imaging, right? Do imaging, right? It's a very important point, doctors. Okay, where else? My PDF. Yeah. Here, without red flag, but suspected fracture is X-ray first, right? X-ray first. So don't confuse the points. You can easily understand, right? Okay, so yeah, next question. Look like Bartholian cyst patient in severe pain. Initial best step. Okay, before going for this question, I will explain different things. Okay, most of doctors have some very deep, how to tell, like they have following something for this the Bartholian cyst question, very deep idea, like even in my head still it's present, like the marsupialization for recurrent Bartholian cyst only, that is completely wrong. That is completely wrong. Okay, I will explain why. First of all, we'll do this question. 28-year old woman present to the emergency department with 3 days of progressive left vulva pain and swelling. She reports similar episode over the past 8 months that resolved spontaneously. She has no significant medical history and take no regular medications. She is sexually active with a regular partner. On examination, she appears well with vital signs within normal limit. There's a tender, fluctuant 3 centimeter mass at the left posterior introitus at 8 o'clock position. The overlying skin is erythematous but intact. Which one of the following is most appropriate definitive management? Now tell me the answer. I know you are very comfortable in this question because this is the only question that we have for the Bartholian gland cyst, right? But actually, here it's the fluctuant mass, right? It's like an abscess here. Okay, I'll explain. So, marsupialization. The patient presenting with symptomatic Bartholian cyst with features suggesting superimposed infection, abscess, right? Because the fluctuant mass, like if you see a fluctuant mass, think about abscess. Very familiar word, right? The history of recurrence suggests that need for the definitive management rather than temporary measure. Okay, that is a very good point. Okay, here, there. We'll discuss marsupialization is the most appropriate definitive treatment for symptomatic. Okay, one is symptomatic or recurrent Bartholian cyst. That is the most appropriate definitive treatment, right? Definitive treatment. Not only for recurrent cases, it is the definitive treatment for the symptomatic Bartholian cyst, right? Not only for the recurrent one, either for symptomatic case or recurrent Bartholian cyst. The procedure involved the create permanent opening by suturing the cyst wall to surrounding tissue, preventing reaccumulation of fluid. It can be performed under local anesthesia and has a success rate of approximately 85%. Here. Can you see? Okay. Can you see the procedure here? They're suturing wall, right? The gland wall suturing to the. Okay, what is happening with that? Here, what is they are doing? Suturing the cyst wall to the surrounding tissue, right? So there's a no accumulation. That is the best thing you can do, right? Because Bartholian cysts are always very risk for the recurrent, right? Okay, now tell me, what do you know about word catheter? Tell me, doctors. What do you know about when to use this word catheter? When to use this word catheter? I will explain. I will give a summary again. When to use, when to go with word catheter. Okay, here. Actually, for Australia, they have not given a proper guideline for this one. Okay, they have not given for proper guideline for Bartholian cyst. Okay, because I have went through the reference link they have given in e-medicine. They have given in e-medicine that also not mentioned that. Okay, the point is this. So we have marsupialization and word catheter. Word catheter is using like this. So word catheter is using how? So first you are making small incision, right? A small incision, and you are draining it. You are draining in, and then you put this word catheter inside it, and keep it, right? Keep it to like excess things to drainage, right, doctors? It's like a inflate, like you insert it, then balloon is inflated, right? And like you're leaving this catheter for 4 to 6 weeks, right? 4 to 6 weeks. That is one thing, the word catheter. So usually word catheter and the marsupialization both are used for symptomatic management. Symptomatic Bartholian cyst management, right? Is it understandable? Okay, now if they give between if they give two options between from marsupialization and word catheter. Usually if you are doing word catheter, that is always you need to do the incision, then you need drainage, then you need to put this word catheter. That is a one procedure, but IND alone is a different procedure. Okay, it's a different procedure because you need to understand these three things very clearly. Marsupialization, you are opening it, drain it, then you suture this gland wall to the surrounding tissue. That is the best option because there's a no recurrence, there's a no area to accumulate again, right? Accumulate fluid again. So that is the best thing. The other best thing for the symptomatic treatment, the word catheter insertion. You have to make an incision, then you have to drain it, then you have to insert the word catheter, then inflate the balloon, then keep it for 4 to 6 weeks. Okay, that is the another one. What about IND? IND, what do you know about IND, doctors? IND. Okay, IND is, are we using it? IND here. Incision and drainage along while providing immediate relief has a higher recurrence rate. Higher recurrence rate. Here it is having a higher recurrence rate. No, doctor, for abscess marsupialization. Can use marsupialization is the definitive management, but IND you can use for the symptomatic either abscess or cyst. Symptomatic case you can use, but the thing is you are just doing a incision, then draining. That is only like again the reaccumulation can occur. Because of that, this is not the best one. Incision and drainage, reaccumulation recurrence rate is very high. So, because cyst wall remain intact, this is appropriate only for emergency temporary relief of an abscess if a definitive treatment must be delayed, right? If a definitive treatment must be delayed. So, we have definitive treatment as the marsupialization, right? Marsupialization. No, doctor, usually like the centimeter level, they are not like, I know you all are talking about, even I had that the chart, the 3 centimeter, the abscess. That chart is okay, but like there's a no proper guideline like that. That is a European guideline. Okay, that is a European guideline. For from this emergency question, you can collect few things. The symptomatic cases, okay, symptomatic cases, you have what, you have the definitive treatment as marsupialization. Symptomatic cyst or abscess, you can go with marsupialization because recurrent rate is very low. Even though cyst, if it is symptomatic, go with that. Abscess, go with that. That is the best option you have. The another best option you have, if it is marsupialization not given, another other indication is recurrency. You have to do the marsupialization if it is recurrent, but they are not telling avoid in initial case. But if it is like very severe case, you can still use. But you have other option called word catheter. Word catheter also best option for the symptomatic management of this Bartholian cyst. Remember these two as the best option for the symptomatic Bartholian cyst. But if it is a recurrent, mass mobilization, you must go. Recurrent is only one indication, right? One indication. Otherwise, symptomatic cases, you still can use mass mobilization because that is the best thing you can go. And about the asymptomatic one. Asymptomatic one, conservative management with sits, bath, and analgesia may appropriate for first presentation or asymptomatic cyst, but given in this patient's recurrence anyway, like the first presentation also, like very mild cases only we are using conservative management. If it is a very severe painful one, we are not waiting for the conservative because it's painful, you need to do something. Okay, simple excision criteria, higher risk complication including bleeding, scarring, and dyspareunia compared to the marsupialization, and it's generally reserved for case where malignancy is suspected. Right? Here, the Bartholian marsupialization is a definitive treatment for symptomatic O. That means symptomatic cases. This is a one indication, and this is the second indication. So marsupialization. Okay, not only for recurrent cases, so even symptomatic cases you have to use marsupialization. If marsupialization not present, go with word catheter. Okay, incision and drainage, only these definitive management are being delayed and you need the temporary relief. But later you need to do this marsupialization. Very important, right? So in this question, uh, looks like Bartholian cyst patient in severe pain. Initial best step. They are asking the best step, even initial best step. So severe pain. What you can do, marsupialization is a definitive management. It's a one indication is symptomatic, severe symptomatic cases. So still you can go with marsupialization, right? I hope you understand my point. Because all the time you are like thinking only in recurrent cases. No, recurrent cases also one indication, but the marsupialization, it's a good one for this Bartholians is because that is the highest success rate and the lowest recurrence rate, right? So if it is not given this one, you can go with word catheter for the severe pain in severe painful Bartholian cyst, right? I hope you get the point. Okay, next one. Patient having wound on a limb with, I think, fracture. Limb is pulseless distally normal. Limb pulseless and distally normal. What to do first? What you should do, doctors? So what you should do here? What you should do? Why reduction you need to do? What is the reason of doing reduction here? Who can tell me? Next time I will use the other file because today I didn't have time to prepare myself. That's what I use the PDF form. Otherwise, I can erase the marked answers. Mm-hmm. Yes. The problem is what? Yes, to save the limb, right? Yes. Okay. So if there is a open fracture, what you need to be very concerned about treating it? You always have to think about the neurovascular compromise. Very important. Okay, very important here. Open fracture is vascular injury or limb threatening emergency. Early recognition and prompt surgical interventions are critical to optimize outcome and prevent permanent disability or amputation. Okay. If the patient is presenting with pulseless limb, and initially, okay, you have done the reduction. Next thing, what you need to do? Next thing, after the reduction, you need to check it again. Check it again, the pulse, right? Check it again. That is most important. Okay. Still after the initial reduction, also, if the pulse is not present, still called and pulseless limb present, what you need to do? That is the other question that they are asking. What you can, oh, sorry, doctors. What you can do? Okay, initially open fracture, pulseless limb and cord limb. They have done the initial reduction. Then after you are again checking the pulse. Okay. Then still pulse is not present and still the limb is cold. What you need to do next thing? You have to save the limb. What you need to do? Okay. That is the other question they can ask. I will explain that question from here, from this one. Here, 27-year-old man brought to into the emergency department after being involved in a motorbike crash 2 hours ago and injury in his left leg. He has no significant medical history and does not take any regular medications. Initial resuscitation is performed based on advanced trauma life support protocol. Control active bleeding and maintain blood pressure, and currently hemodynamically stable. Further repeated detailed assessment and limb injury is performed. On examination, there is a 7 centimeter open wound over the shin, which clear deformity and angulation of the lower limb and fragmented tibia visible. The fraction is reduced in the emergency department. However, foot remain cold and pedal pulse are diminished. So, what you need to do? You need to do the immediate surgical referral, right? Because you need to save the limb, right? You need to save the limb. This is the point that you must be like very confident. Initially, what to do if the neurovascular compromise present initially in the ED, you need to reduce it, right? You do the initial reduction. Then again, after the moment, you have to again check if the pulse present or not, the call is limp or pale or not. If it is still present, you are not waiting for the antibiotic. Whatever you are not waiting, you just go with the surgical referral. During the surgical referral, like after preparing for the surgery, then you can give the antibiotic, right? But you should not delay for anything if this is like pedal pulse or the pulse is diminished or pulse is absent, the cold limb present, right? Here immediate surgical referral is the most appropriate. Next, this patient has open tibial fracture with hard signs of vascular compromise, cool foot, diminished pulses despite initial resuscitation and stabilization. Immediate surgical review is required to assess the possible vascular repair and limb salvage. Delayed for further imaging or other interventions, a risk irreversible ischemia and limb loss, right? Here, plain X-ray is important for fracture assessment but should not delay urgent surgical intervention. Okay, here. Intravenous antibiotics are essential in open fracture to reduce infection risk, but the context of the vascular compromise, restoring perfusion take priority. Antibiotic can be given during the theater or intraoperatively, right? Okay, there's another question. Another question. 28-year-old man present to the ED After motorbike accident, he reports severe pain in his right leg, which is unable to move. The injury occurred 1 hour ago. He has no significant medical history and does not take any regular medications. He works as a mechanic and does not smoke. On examination, appeared distress, pulse rate 110, BP 130 by age, respiratory rate 18, SpO2 99, temperature 36.9, 6 centimeter wound over the anterior aspect of the right tibia with exposed bone and active bleeding. The foot is cold but pulses are palpable. Sensation is reduced over the dorsum of the foot. X-ray confirm a community mid-shaft tibial fracture with displacement. Which one of the following most appropriate initial management? Okay, I will give most appropriate initial management. I will give the answer. You need to answer me, okay, because that is already marked. Okay, wait a minute. Okay, options are apply backslap, plaster backslap, uh, wound closure in ED, plaster backslap, wound closure in ED, IV antibiotic, immediate operative fixation. What do you think? Plaster backslap, apply a plaster backslap, wound closure in ED, intravenous antibiotic, immediate operative fixation. Now you tell me the answer. Yes, very good. Why IV antibiotic? Why? What is the reason? Yes. Intravenous antibiotic is the answer, right? Yes. Intravenous antibiotic. Why? They have not mentioned anything about vascular compromise, right? Everything seems okay. So then, okay, so what is next priority is the infection control because there's a no problem with the vascular compromise, right? Yes. Infection control must be approach, right? Can you see, like if you only do this question or the previous question alone, how you can differentiate? Like you don't have a proper idea, right? You need to do this question to get an idea to differentiate, right? Yeah, otherwise, because the next question this question was wrong. Why? Because when I was doing the session, the recall sessions, not in this one, I think this is February, I explained first. So so I discussed this question, then I asked the doctors about the next question. They all marked again as IV antibiotic, right? Because the tiny point you are not noticing, and you always think if you see one point in images, you always think next also the same. No, that is different. That's why you need to go through these questions very carefully and separately, right? You need to understand tiny details here. Why IV antibiotic? Most appropriate initial step in the management of an open fracture. Early administration of broad spectrum antibiotics significantly reduce the risk. Yes. So here reduce the risk of deep infection, which is major complication of open fracture. Antibiotic prophylaxis should be given as soon as possible. The most open fractures. Some exceptions include facial trauma not requiring surgical management, isolated distal phalanx or finger promptly. Treated within 8 hours, ideally within 1 hour of presentation and before surgical intervention, right? Okay, so I hope this is understandable. Okay, I'll explain here. So remember like this. If it is infection risk is a priority, think about antibiotic early. But ischemia, limb death, present. Limb death is ongoing. The features called limb, right? The diminished pulses. In that case, more urgent than infection. Perfusion is the first, right? Infection second. If ischemia present, right? So pulse present antibiotic first, pulse absent or call limped reduction first. I hope this is very easy for you to understand, right? Okay, there's another complication you need to remember when we discuss about these fractures, because that part they have asked in June exam. The part is compartment syndrome. Compartment syndrome. Okay, we'll do this question as well. 55-year-old man brought to the emergency department by ambulance after being involved in a motor vehicle accident where he sustained a soft tissue wound deeply back of his left leg. X-ray shows the tibial tibial shaft fracture, which is reduction in ED with applications of Long's back slab. The patient is 1 minute, doctors. Okay, so here applications of backslap. The patient is taken to the theater that night for definitive treatment with external fixation. He is reviewed in the ward several hours after the procedure and he has increase in pain in the leg despite being given analgesia according to the standard protocol. The patient is agitated with blood pressure 156 by 90, pulse 104. There is a positive passive stretch test but no association, paresthesia or paralysis. Vital pulses are palpable. Now tell me what is the answer. Easy question right here. So the concern must be all possibility of the development of compartment syndromes of 5 P's: pain, paresthesia, pallor, pulseness, and paralysis. The pain is earliest sign of the compartment syndrome. Without intervention, this condition can lead to the irreversible tissue injury or Walkman's construction, right? So treatment on the body include remove all circumstantial resin and plasters. The sorry, the leg is not too elevated as this reduce the perfusion and extremities. Adequate analgesia should be given. Prompt contact must be made with the orthopedic team for the fasciotomy, right? So when you are doing when you are doing the open fractures, you have to think about the infection risk, neurovascular compromise, then the compartment syndrome. These three are the main complications that can associated with these open fractures, right? And so in that case, you need to know like when to go with this compartment syndrome is easier part, because you can identify with these 5 P's and you know the treatment, remove all the circumstantial dressing and refer for the fasciotomy. But the other things are the main thing. But I show you like how to go with reduction first, how to go with antibiotic first. So make sure those things are very clear in conceptual way, right? Okay. Okay, this is the question that I was telling. All age female have enough fatigue, backache. What do you want to investigate? Okay, this question is very incomplete, but can you see the options they are given? Serum protein electrophoresis, serum calcium, MRI, and the fatigue, back pain. Like we can think about multiple myeloma. We can think about multiple myeloma, right? By having fatigue is present in the multiple myeloma. The back pain is one of like a prominent symptom in multiple myeloma. Okay, so it's fine. Like even though we are getting like this much incomplete, we can think about, but I can't tell it is 100% multiple myeloma, but we can suspect it as a multiple myeloma, right? Okay, we'll discuss about multiple. Do you remember the question? No, not this one, right? Okay. Yes. We'll do this question. Then I will explain about multiple myeloma. Sorry. A 68-year-old woman presented to the GP clinic with 3 month history of fatigue, back pain, and recurrent chest infection. She has no significant medical history and does not take any regular medications. On examination, she appears pale, pulse rate 72, blood pressure 120 by 80, respiratory rate is 16, SpO2 98, temperature 36.7. Blood test revealed hemoglobin 98, creatinine 130, urine analysis shows plus 2 protein. Further urine testing revealed protein creatinine ratio of 350. Then albumin creatinine ratio of 50. Which one of the following most appropriate next investigation? So what do you think? So now type your answers, then I will explain. Easy question, right? Wait, what? What is the answer? Okay, okay, interesting. Okay, here. In the stem, what you can see. Sorry. In the stem, what you can see. The patient present with symptoms and laboratory findings suggestive of multiple myeloma. Right? The most appropriate next investigation is serum protein electrophoresis. Very important, which can detect the presence of monoclonal protein or M protein in myeloma, right? The clinical picture consistent with myeloma. Okay, now remember the myeloma features: fatigue, likely due to anemia, back pain, possible from bone involvement, recurrent infection due to immunodeficiency, anemia, renal impairment, proteinuria, right, based on protein. Notably, there is a disproportionately high protein creatinine ratio compared to the albumin creatinine ratio. The discrepancy suggests the presence of non-albumin protein in the urine, which in myeloma are typically monoclonal light chains. We call it Benz-John protein, right? Very important. Benz-John protein, right? Okay, what do you know about multiple myeloma? Can you tell me about multiple myeloma? Okay, what is happening in multiple myeloma? Multiple myeloma. What is happening? So the problem is what? It's a plasma cell malignancy, right? Characteristic by clonal plasma cell proliferation in the bone marrow and the monoclonal immunoglobulin, or we call it M protein production, right? And that can lead the this organ damage. Usually we call it crab, right? Crab. So what is happening in crab? If there's organ damage present, there can be hypercalcemia, right? Crab hypercalcemia. What else you can see? Renal R mean renal impairment, right? A mean anemia, right? Anemia. B mean bone lesion, or we call it lytic lesion. You can see because of these lesions, you can see the fractures, right? Fractures and lytic lesions, right? Yes. It is. Uh, we just open. I think more than it's almost around one hour and a half. Yeah, 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 doctor. Okay, okay. And what are the clinical features you can say? Clinical features. If it is associated with the bone, you can see the persistent back pain. That is the most commonest feature, right? The rib pain can be seen pathological fractures, vertebral compression fractures can also see. Hypercalcemia. Because of this hypercalcemia, what you can see polyuria, constipation, in confusion, right? Dehydration can be associated. The renal impairment because of this protein, right? Proteinuria, Benz-John protein can be acute kidney injury, right? Then anemia, due to anemia, there can be a fatigue, pale, dyspnea, right? Can be present. Due to this, imbalance in these immunomediators, there can be recurrent bacterial infections, right? Recurrent upper respiratory tract infections, pneumonias, right? UTIs can be associated. Other than that, There can be peripheral neuropathy as well, right, doctors? Yeah. Okay, so if you are suspecting these multiple myeloma from these clinical features and the laboratory features, the CRAB criteria, laboratory features, so what you can, you need to screen for multiple myeloma. Well, multiple myeloma, right? Multiple myeloma. So the main test is what? Serum protein electrophoresis. SPEP means serum protein electrophoresis. That is the initial, or they can ask most appropriate. So, whatever they are asking, this is the best. Serum protein electrophoresis. And serum protein electrophoresis. Other than that, you can find the serum free light chains, right? Those are the things that you can see. Then, other than that, okay, here, if you find out M protein absent, normal FLC ratio, so multiple myeloma unlikely. If it is M protein present or abnormal, uh, free light chain ratio present, possible, right? Okay, screen for CRAB criteria. So CRAB features present. So you have to do the referral. And if features are non-urgent OPD referral. Okay, so that is not very important, these two things. Now tell me uh, what is the management? How we should manage these patients? Very important because they are asking from this part. Okay, management depend on the age and associated comorbidities, very important. Okay, manage and age and associated comorbidities. If you're not very familiar, just write down multiple myeloma treatment depend on age and associated comorbidities. So what is the age? Here for those younger than 65, write down the 65, younger than that, or those who with sorry age 65 to 70 with few comorbidities. 65 to 70 also okay, but less comorbidities, okay? In that case, you can do the definitive treatment, autologous stem cell transplantation. So, definitive treatment is stem cells transplantation, right? But before doing the transplantation, sorry, before doing the transplantation, you need to do something else. Okay, here newly diagnosed multiple myeloma, you have to check their transplant eligible according to the this age and comorbidities. If it is more less than 65 or within 65 to 17 with few comorbidities, he is eligible. Then you need to go with induction regime, typically using combination therapy before doing the induction therapy. uh, before doing the transplantation, you need to do the 3 to 6 cycles of induction treatment, aiming to achieve the complete or near complete response prior to the their transplant. These have been significant advance in choice of induction agent in several new agents that have improved response. Multiple myeloma, the best result appear to be achieved with the combination of what? A steroid, chemotherapy, cytotoxic chemotherapy, and the third drug is what? Immunomodulatory agent. These three are the combination therapy that we are using as the induction therapy. And very important. Then induction regime typically used in combination therapy. So remember three things that we are using. Then you have to assess disease assessment, at least partial response achieved. So then after the induction therapy, you have to check if partial regime is achieved or not. If it is achieved, then you can do the transplantation, autologous stem cell transplantation. Then after transplantation, you can consider maintenance therapy with this novel immunomodulatory agent. So if it is disease assessment, like at least partial, not assessed, then what you need to do, you have to do the salvage induction regime, including novel agent. So you have to do the salvage induction. Then after that, at least partial response achieved after salvage induction. Again, partial after salvage induction, the appropriate response is achieved, then you can patient is eligible for autolog stem cell transplantation. If it is not response achieved, then you have to again salvage therapy with new alternative agents, because we have other agents like proteasome inhibitors like that. Okay. Okay, here patient is not transplant eligible. That means more than 65 with more comorbidities or more than 70, right? So combination therapy with choice of novel or traditional agents. So you can use combination therapy without doing transplantation, right? I hope everything is understandable. And here we'll do this question as well. This is also can be asked. 62-year-old man present to the GP clinic with 2 months history of increase in fatigue, 8 kilogram weight loss, and increased urination. He also has dull pain in his arm and leg. He has no pre-existing medical concern and take no regular medications. He is a non-smoker and drink about 3 glasses of wine a week. He undergoes regular bowel cancer screening and drink about screening. There is a no family history of any cancer. On examination, he looks pale. Blood pressure 125 by 90. The pulse is 90. The temperature 37. The rest of examination is unremarkable. Initial investigation revealed that he is hypercalcemic with decreased parathyroid hormone and normocystic anemia. Which one of the following most likely to be positive? So it's a serum free light chains, right? Because the ratio should be increased. The clinical picture, multiple myeloma, this diagnosis would account for the patient's hypercalcemia manifesting with polyuria and lytic lesions, causing this bone pain. Paleness would be also explained by normocystic anemia. Biopsy of the bone marrow and urine electrophoresis should be conducted to confirm the diagnosis, but those are later, okay? The biopsy is very late thing. Okay, biopsy is like a very late thing if only we need it. But otherwise, the electrophoresis is the best gold standard. Like whatever, the best thing is electrophoresis. Confirm the elevated serum free light chain associated with the multiple myeloma. Yeah. Okay. Okay, doctors. So actually, I can't speak more. Like my throat is very much irritated because I was sick. So I think I hope you got like a good idea about few topics, right? So because of that, yeah, we have done 1 hour and a half class. I have done the recording, so I can upload this later. Okay, and thank you so much, doctors, for joining. Okay, next day I will do extra time because today I can't actually speak very well. And yeah, thank you so much, doctors, for joining. Yeah, tomorrow most probably we can do the session earlier. And thank you so much, doctors. Yeah, we will meet tomorrow. Have a good day, doctors. So we will discuss ops tomorrow because it seems like even in my recall, my paid classes also, doctors are struggling with ops. So I think better you should understand the concept properly, because ops is like always a logical thing. At the same time, you have to follow the sorry guidelines. Right? Okay. So have a good day, doctors. Thank you so much. Bye bye.